And I would now like to invite Teresa Trabert from Denver Health to the stage to discuss palliative care and hospice. Welcome, Teresa. Thank you.
Good morning. Well, this is pretty loud. I talk loud anyway, so I'll stand back a little bit. I got a loud mouth. So this is absolutely one of my most favorite conferences. I think I've been coming to this conference for like 17 years now, and so I'm really excited to be able to present for you all today. I'm super excited to be around such amazing nurses who take that initiative to do the extra. You don't have to come spend your entire day in a conference room and looking at slides and all of that, and so just taking that initiative to truly increase your knowledge and ultimately improve patient outcomes. So that is a huge deal for me to be able to be up here today. I spent a lot of time thinking about what do I want to try to share, what pearls do I have to present, and when palliative is so truly vast, and I could have dove into multiple avenues, and I was like, well, what are these nurses going to be able to use in their daily practice regardless of setting? Whether you're a nurse clinician in your outpatient oncology clinic, whether you're in the infusion center treating those patients, or in the inpatient setting. And I kept coming back to just talk about primary palliative care. And so that's what I did today. Let me see. Where's the... Oh, here. Okay, just like that. I'm going to put my timer on because I'm not sure if they have one. I'll talk forever about stuff. So palliative care truly is specialized medicine. It is for any patient, regardless of their diagnosis. It should be somebody who is terminally ill or chronically ill, but it can also be provided with somebody who has a curative intent. So even in active treatment while they're trying to get as much time as possible. We are experts in our symptom management. We specialize in goals of care conversations with the patient and the family, and we assist in advanced care planning. So that kind of, in a nutshell, talks about palliative care. When I think about palliative care, when I'm teaching my residents when they come, or my other nursing students, I try to have them to envision an umbrella. So underneath it, palliative care is this umbrella, and underneath this umbrella there are a lot of facets that you can use, but it's easier if you take all of those, if you just kind of clump them into categories, and that's why I do goals of care, symptom management, and advanced care planning. And if you think about an umbrella, it helps to protect you from the rain, right? And so I use that umbrella because it can help to protect our patients from interventions that they really don't want, or that ultimately are truly not going to add quality of life or aren't going to meet their goals of care. Just because we can do something doesn't mean we always should, right? So talking about primary palliative care, so palliative medicine truly is a specialty field. We have our fellowship program for our physicians, we have postmasters programs for our nurses, we have certifications. You can get in palliative medicine for CNA, LPN, general nursing, or advanced care practice. But it doesn't take a specialist in palliative care to start to talk about some of the basics of care, of what you should do. I think nursing assessment is number one key. Just like at times you're like, well, it doesn't take a rocket scientist. Well, true, and it doesn't take an additional 3 years of training in palliative medicine to do an assessment to figure out who might need it. It's really just making sure that you're aware of what palliative medicine can bring to the table and how we might be able to add care to your patient. Our physicians can do it, our general medicine teams. It doesn't even have to be an oncology provider. We have our chaplains, we have our social workers, and we have our nursing staff that can do some of this primary palliative medicine. When I break them two up, I kind of think about primary palliative care is it's the surface. It's the initiating the ask. How are things going? How do you feel mentally or emotionally you're coping with your treatments? Wow, so much has happened so fast. How do you think things are going at home? So it's kind of just getting that surface and gathering that information so that you can do a better evaluation of, wow, do I feel that we're truly meeting this patient's needs, or do I need someone that does that deeper dive? One of the basics, I'm sure Well, I would hope, anyway, I hope you guys have just been talked to death about advanced care planning. I hope that you guys have been like, oh my God, not again, not advanced care planning. Because then that's good, because this is like the most basic thing we can do for our patients is documenting what their wishes are. So Colorado Hospital Association puts out this really good book, Your Right to Make Healthcare Decisions. This can be found online. In reviewing other states, because I know we have a lot of people that are on the phones that aren't from Colorado, and this conference has actually gone nationwide, which is really cool to me. Iowa also has one, Texas has one, and those are just some of the places I was familiar with that I Googled just to see what do they have compared to Colorado. Within this book, they have the forms that you can use for your patients, which include your medical durable power of attorney. I'm just kind of out of curiosity, how many people know that if something happens to you, if you lose that ability to speak for yourself, that your husband or wife or next of kin becomes your automatic decision maker, right? So in some states, that's true. They use this hierarchy approach. In the state of Colorado and many other states, there is not necessarily an automatic hierarchy. So if you haven't yourself, I should go back to say, durable medical power of attorney is someone that you have picked for yourself that you trust to make medical decisions for you. What do I want? What do I not want if I can't speak for myself? It is not like, well, who do you want me to contact, if something happens? It's not your emergency contact. So it does take that general baseline knowledge so that you know what a medical durable power of attorney is so that you can then educate your patients on what that is and what that means and why this is an important role and why it's important to take time if they need to think about who they trust to be in that role. But anyway, so it doesn't automatically go to your next of kin or your husband, which some people are very surprised by. Well, of course it would go to my husband, or of course my dad would be in charge. If you haven't taken the time to assign for yourself an MD POA, Colorado requires us to do a proxy process, which means we get whoever we can that is showing up at the table. Who is showing an interest in your care? This could also be your third cousin removed, who you never really liked anyway, but they're showing up. And so they are part of those people that come together then, and then we challenge them to discuss among themselves, of all of you who are here, being an interested party, who should be the person in charge? And lo and behold, nobody wants to do it except your third cousin removed, who were like, seriously? But you don't know because you can't speak for yourself. And so we really urge you to talk to your patients. It's the easiest ask you can do for your patients to gain what their interest is in as far as their decision makings. And you don't need a physician's signature. You don't need anybody's signature other than the patient's. And matter of fact, we really urge staff not to. Everyone's just like, oh, I'm going to sign this as the witness because then I've really done what I've done and it's all complete. And most institutions do not allow your medical staff to sign as a witness on a form. So, but it takes a patient signature, the person's name of who they want, and a date. That is a legal document in the state of Colorado. As far as other states, I don't know all the nuances of your specific state legislation rules, so I would urge you to look those up yourself as well. Also in this form is your Colorado, or a CPR directive, and that advanced care nurses or advanced providers like PAs, any of your advanced practice nurses don't have the ability to sign that particular form. Matter of fact, I don't know of a single state that does allow that. So someday in my spare time, I've always said I'm just going to go flail my body on the Capitol steps and let's make a change so that we can get this done. But I haven't had my spare time to do that yet. But I'm hoping that sometime, God Lord, if all of us women and men in nursing field joined up together, we could truly move mountains. And so that's hopefully a project in the future. And then there's this living will. And living wills are pretty funny because, people will be like, well, I'll be okay with this for 10 days. And when I see that, I'm always like, oh, Lordy. So well, you're starting to recover on day 9, and so if you're not up and about by tomorrow, should we just call it? So, but families, they want to honor their loved ones, and so they'll come in and they'll be like, they're truly distressed. They're like, we have this. We know that tomorrow is what Aunt Sally said. We want to honor her. And so taking that time to sit down with them to be like, absolutely, you're making the best decisions that you can with the information you have together. Let's talk about how things are going. Recommending a palliative care consult. Okay, the family seems to be a little bit torn about what the goals are here. Maybe we just need a time out to sit down and talk about things. So those are some of the things in this book. I'm going through forms today because I've had some interesting experiences. So this is what is called our Colorado MOST form. This is it's an order set, basically. This isn't a true advanced care planning form. This isn't a legal document, really. What this does is it allows advanced care nurses and providers and PAs to sign a document that helps to validate we've had the conversation. The patient is this full resuscitation or not resuscitation. These are the levels of care that they would be okay with. They absolutely would be okay with an ICU stay. We talked about it. This is what they want. And we support their decision, making sure our job is to educate, right, not to make decisions for them. So we give them all the information that they need. Or they would never want to come to the hospital. Like, that's their line in the sand. If it gets to that, no, I'm comfort measures only. Only bring me here if I can't be comfortable in my current care setting. So that talks a little bit about it. It also includes artificial nutrition and hydration if that's something that they would want. On the very back of this form, you can write who the MDPOA is if you happen to know it, but that is not a legal MDPOA form, so don't take advantage of that. A lot of states use these types of forms. I know California has POLST, Iowa has one. I'm sure a lot of other states have scope of practice too, but the problem is people misinterpret this for a documented legal advanced care planning form, and that's not what it's intended to be. In fact, if you look at the Colorado State statute, when you're reading this weekend and like scrolling through those paragraphs, you'll find that it says, a physician can revoke this, a medical decision maker can revoke this, so that's not set in stone. Going back to a true Colorado CPR directive, only the person initiating that directive is the one that can revoke it. I've seen this happen in practice where a patient has clearly stated what their wishes were. The daughter, who's emotional, comes into my ICU, or not my ICU, it's y'all's ICU, but wherever I'm at, and they're like, Mom would never want this. That was a misunderstanding. They didn't want that done. I want this revoked. Resident's like, freaking out, revokes it. I'm like, no. This is totally against, you just uprooted all of this. That's totally not cool. It's unethical. It's against the law, I'm sure, because this was set in place for that, so it's against our statute. So things to keep in mind with that one. This is our 5 Wishes book. I love and hate this book. Some of the wording in it is pretty complicated, and so when you have a general patient population that is 4th to 5th grade reading level in some of our underserved communities, this isn't the easiest book, but it does allow you to have something is better than nothing. And so I will use this book. It's common, it's nationwide, it's probably the most frequently used tool to start the conversation. Generally families don't get together and be like, hey, what are you guys doing Friday night? You want to come over and have pizza? Talk about what if things don't go as well as hoped. Unless you're my family. My dad's an elk hunter, and him, one day we're sitting in Chili's, he's like, well, Teresa, one of these days I'm going to go to that big elk haven in the sky. I'm like sitting there eating my chips and salsa, tearing up. I'm like, seriously, Dad, what is wrong with you? I recently moved to Texas, and so my parents were like, we need to have a dinner. So I'm like, okay, so we got together. We're at P.F. Chang's. And, my dad's like, well, you never really talked to me about what you want done with your ashes. And he's right. But seriously, we're at dinner in a public place. So I'm like, well, what do you want done with your ashes? With my pot sticker. I'm like, we're the weirdest family. So we do get together and eat and talk about the weird things, which maybe is how I ended up in this role. But most families don't. And so this 5 Wishes is a book that can be helpful. I got this. So advanced care planning in a nutshell. I just wanted to make sure that you guys at least have the foundation tools to know, number one, you absolutely can, as a nurse, go to that patient and learn about what is, driving them. If they're seeking treatments, what is it that's, with their wishes? Like, have they ever thought about who they'd want to be their decision maker? I try to normalize it as much as possible. You don't always have to go in with the, what if things don't go as well as hoped? I use that line a lot because it helps to say, I know, but I always start off with the positive. I know we're believing for the best. You're absolutely seeking treatment. Your goals are to get as much time as possible. But I don't know the other things. I don't know what your line in the sand is. I don't know, if you've ever thought about, anything could happen. We live in Colorado. We could slip on ice, bump our head, maybe be confused, knock on wood, that doesn't happen. But normalize it. And then they might be able to tell you who they would pick and make sure they understand what their understanding is of an MDPOA. And so hopefully you can take all of that, know that a nursing absolutely is able to do it, our chaplains, our social workers, it's just the patient's signature, and get the form. If it's not documented, it wasn't done. Our whole entire lives we've heard this, but it's so true. So it's gonna be a lot easier for their other providers who are caring for them. So symptom management, I wanted to touch on this a little bit. In oncology, all of you guys are assessing your toxicities and what's going on with all of that. And so I thought I'd go over just kind of like 4 things. Constipation, it's always twofold, mush and push. We're not supposed to say name brands, so I don't know if I'll get in trouble for using this or not, but I don't really use Colace that often. There was actually quite a few studies out that showed it wasn't adding a whole lot of benefit. What it was adding was a whole lot of pill burden. And so oftentimes I'll just use Senna to get things out and use things like prune juice or other natural things just to keep things going, making sure they're hydrated and things like that. If I have a patient who has extreme fatigue or depression, I might use Ritalin, short term, like 2.5 milligrams twice a day. It's just enough to give them that bump. This is a medication they use for ADH kids, but it actually gives adults a little bit of extra energy. Keep in mind the effectiveness of it does wear down. So I had a patient who was really poor quality of life, couldn't do anything, had zero drive, was I think on her 3rd or 4th line treatment, just not thriving. And she's like, I really miss being able just to get up, and me and my husband used to cook dinner, and we, these are the things that brought my life joy. I don't even have energy for that anymore. So I started her on 2.5 milligrams twice a day, and my nurse was like, she's called, she feels great, they cooked dinner the other night, she had the energy, and was doing really good for a while. Problem is, it is short term. I generally will only use it for about 2 weeks while I'm bridging over to an antidepressant if I'm using it for depression, but for fatigue, it depends on where they are, right? It depends kind of where they are and how effective it is. Anorexia, lack of desire for food, I'll use Remeron. I usually use a lower dose. Supposedly that helps more with hunger than the higher dose of 30 milligrams. Problem is lower doses actually increases sedation, so I sometimes will use it for sleep as well. But keep that in mind if you have elderly patients, I'm just gonna start them low on 7.5. May not be as good as a higher dose because of the other side effects of it. And depression, I always really encourage using non-pharma remedies if you can. I use a lot of distraction therapy. Revisiting. What was it like before this? Before I was like your date every other week, what did you do before this? And trying to see, are there ways that we can reincorporate normalcy back into their life? I had a patient who reconnected with his wife, and they started just going to lunch once a week as a set date. And it was amazing how much that improved his overall quality of life and the joy and decreased the depression. So things to keep in mind there. And improving quality of life. I always, palliative care and quality of life are two things that I try to connect all of the time. With palliative care, our number one goal is to elevate quality of life for our patients while they're getting their treatments, to live the best life they can, to have their symptoms managed. Palliative means to cloak, and so we hide those symptoms to try to help them have some normalcy in their life. While hospice, on the other hand, tries to help them have the best quality of end of life. So there's a big difference there, even though at times we're kind of ballooned together. And challenge you guys all. There's a lot of QI initiatives you absolutely could do with just primary palliative care, of figuring out back in the day, I did an evaluation of our hospital of kind of like, okay, well, who all is filling out our advanced care planning forms? And I compared our, palliative care providers to others. What I found, like around 5 years ago, that even palliative care providers weren't doing that great. And like, it's the basic of the basics. I was like, come on, team. Well, like, what are we doing? So we've since improved from there. And then our nurse clinician at the institution where I was at actually took on another QI initiative, and really to see, with the true goal of how do we up our numbers of people who have advanced directives completed. And I think the goal was like at least 85% or 90%, which is a pretty high number, but it was a great QI project, and she was able to take that on and apply that to clinical ladder if you have one of those at your institution. And another one is, end of life. QI initiative could be something that you could do, even though, my passion is not necessarily making sure people have the best end of life possible, or I would have went into hospice medicine. However, there are times that our patients, they don't get to hospice. They're in the hospital setting. We talked earlier about how many patients aren't, especially those divorced who aren't getting into hospice and not dying at home, and they actually are coming to the hospital but lacking that support. And so, if we can't get them there, then how do we help them to have the best quality end of life available? And I always go back to Nursing 101, just the environment in itself. Getting the IV pumps out of the room and all of the medical equipment, helping the family to understand, maybe we can make this look a little bit more like home, so they don't necessarily think you're taking away, but that you're more adding to. And then I just included some resources here for you. This talks a whole lot about LNEC, End of Life Nursing Consortium, that helps for patients who want to, for staff who want to be able to try to improve end-of-life care in their facility, and then a bunch of palliative resources as well. So does anybody have any questions? Oh, there's someone over there. It's really bright up here, so it's like, let's see. Okay.
Good morning, and I apologize if you did address this, but in regards to your advanced directives and all those other forms, how do those cross state lines? For example, if mom filled it out here in Colorado, traveling to Texas, how does that work?
That's a really great question. So I've had patients who we've done some advanced care planning, and their intent is to get back to Mexico. Okay, so I'm like, oh wow, how are we going to make this happen? Like, well, we got a van. And I'm like, oh, well, they're not going to get there by plane, so okay, let's see if this is truly possible. Knowing that anything could go wrong at any time. They're stable right now, and if you're going to do it now. But if you're going through these state lines, going through other states, you might need to go to a hospital. So I make sure they have all of their forms with them. It is state-based, so what is legal here is not necessarily legal there, but having a form will help those other medical authorities that even though they might have a different set of rules set forth by their state statute, they at least have a blueprint of this is truly what the patient wanted. Getting the forms witnessed if they are going, like I fill out MDPA forms all day long. I don't bother with the witness. I have it there. If I know that there's an upcoming plan, that's when you want to move forward with some sort of witness process. And again, it shouldn't be medical staff, but that's what I do. Anybody else?
Hi, Teresa, in the back. I think palliative care is often misconstrued as the transition vehicle into hospice care, which is not the case. So what do you suggest as nurses, the verbiage we use when we're discussing palliative care with our patients so that it doesn't get misconstrued?
Yeah, that's a great question, and you are absolutely right. It is very unfortunate that some of my patients that get referred that I may only follow for 3 to 4 months until I have to transition them over to hospice, which is really unfortunate because we could have been doing such better quality symptom management, working through what their goals are, and things like that before a time of crisis or before it was getting towards the end. Verbiage is hard, right? It's like, what's my elevator speech? You know, I absolutely full-heartedly believe that a nurse who has done a complete palliative assessment and identifies, oh, just the basics, well, this person has stage 4 cancer, that's an automatic referral. You know, you have to think, right? You just have to read, oh, stage 4. So being able to do that assessment, I think using the words, you know, going to your providers and maintaining that good rapport with your oncology providers, being able to talk to them to say, you know, I've noticed a few changes, or I'm noticing some things that I think we might be able to get some extra help in clinic. Also, I realize that you do excellent symptom management for patients who come to clinic, and I also know that your time is very limited, often, you know, only 20 minutes for a follow-up session. When you're also managing all these other toxicities, we could incorporate or do a referral to palliative medicine to ease that workload and partner with them. And so I use partnership a lot. We're absolutely not wanting to take over, but we truly want to work alongside our oncology providers. And so some wordage like that might help. Does that help at all? Okay. Any other questions?
Hello.
Hi.
So one thing we run into at our facility is that our palliative care team is booked out like 2 months in advance. So we have patients going downhill very quickly, needing these really serious goals of life, conversations and pain control and symptom management. And I know we discussed some of the resources there and like some symptom management, but do you have any other suggestions for how we can better support our patients in the interim of getting them in to see a palliative care provider?
Well, I'm recently unemployed, so where are you?
Oh,
I'm just kidding. I don't wear this state anymore. That's the only reason why. So, obviously, going back up to leadership, I mean, I'm sure the chief is evaluating and showing the numbers, saying, look, we're booked out. We have a patient population that is underserved. It shouldn't take 2 months to get in. That's one of the reasons why palliative medicine is there, is because it takes 3 months or 2 months to get into your primary care doctor. And so, truly, it's clearly a lack of resources in the institution. That being said, there's also a lack of resources to fund expansion in most of these places. If I can't meet my patient's needs and if I know that they need it, I refer out. You can refer out to a different company. Most places take it. There's clinics, hospital-based clinics that offer it, so you could figure out what hospital institution is close to them. I also refer to home palliative care. Even if I can get them in, sometimes it just isn't, it's not meeting their needs as well as it could. And so sometimes that could potentially be, of the patients we're currently serving that we can't already meet the needs of, you know, are we doing a better screening form on who might benefit better from home palliative care? Because clearly we can't meet the needs of where we are anyway. So that might be an evaluation screening tool of who truly is appropriate for our palliative clinic at whatever particular institution you're at versus, you know, who would be better served at home, even though we're trying to keep that revenue. I'm very biased to our clinic. I think we do excellent care, and you know, I have my social worker there and the chaplains and an excellent nurse who's, you know, board certified and as a palliative and hospice nurse, and so I think we're great, right? But that being said, if I couldn't get him in, something's better than nothing. Right, so that's my thought about that.
Thank you.
I think we're out of time, unless there's any other. Okay.
Thank
All
you
right,
so
well,
much.
Thank you.